Good afternoon. Good afternoon, and thank you everyone for being here, and thank you to all those online who are joining us virtually. We have an outstanding attendance, so thank you for being here. This is a very important plenary on healthcare and the future of healthcare. Before I get started, I just want to make sure that everybody understands that there is homework involved in this plenary. I want you to consider, whilst you are hearing from our excellent panelists today, if you were to look ahead 20 years, which will go so quickly, what would you want for healthcare, and what is the single word that would describe success? So think about that whilst you're listening to our panelists today, and then we're going to collect your answers. Today I have an outstanding panel that is going to share some different perspectives in healthcare with us. We have 3 panelists. We have 2 here in person and 1 joining us virtually, so thank you for that. First, we have Oksana Pyzik, who is here as the Associate Professor at the University College of London School of Pharmacy. Nazneen Rahman, who is online with us, CEO of YewMaker, Director of Sustainable Medicines Partnership, and Tracy McClelland, Chief Clinical Information Officer, Dedalus UKI. And so without further ado, I'm going to introduce and welcome Oksana to the podium. Thank you for joining us.
As consumers demand more and more convenience, faster services, and more options, healthcare has gone digital. And this is largely a good thing. We have rural areas getting expanded access to care, able to reach otherwise people who may be isolated. However, there are risks that we need to mitigate too, those being falsified medicines. But what is a falsified medicine? You may know it as a fake drug, anything that misrepresents its identity, composition, or source. We don't know what's in it. We don't know how it was made, if it was in sterile conditions, if it has any active pharmaceutical ingredient at all. There's an important differentiation between a falsified medicine and a substandard one, and that is criminal intent. Organized criminal groups enrich themselves through the sale of falsified medicines, whereas a substandard medicine has a legitimate manufacturer. It could be that there was poor manufacturing practice, or somewhere along the supply chain, or at the end point, the medicine was exposed to either heat or humidity that degraded the quality of the product, making it substandard. And then an unregistered or unlicensed product is something that is just not authorized for that country. With falsified medicines, however, sometimes you may hear of this interchangeably as a counterfeit medicine. However, the WHO ditched this term. Previously, it was known as spurious, substandard, falsely labeled, falsified, counterfeit medicines. A mouthful, very confusing. Counterfeit is viewed as more of a trademark infringement and not a public health issue, and that is why in WHO language, we use falsified medicines. And this has a huge cost to health, a huge cost to our economy as well. We know that this is the most lucrative illicit trade that there is. It beats out illicit drugs, human trafficking, all of them. You can make $200 billion in terms of the whole market worth. And that costs us in the long run because we have people who may have a disease that then progresses into disability or, in the worst case scenario, even death. 1 in 10 medicines in low and middle income countries are either substandard or falsified, which means 1 in 10 people could end up being harmed as a result. Now, in some countries, that statistic is much, much higher. And in high-income countries, it's usually more due to online, illegal online pharmacies, people going to social media to purchase products. What we see is that this can then, as a result, lead to a degradation of trust, not only in healthcare systems, healthcare professionals, but in the medicines themselves. And in this environment now, trust is already very shaky. Here are some examples of falsified medicines. For the first time ever, WHO had alerted, it's a global alert to say they identified falsified Ozempic. This is known as some skinny jab. Semaglutide is the active ingredient in the US, the UK, and Brazil. And this is in the legal supply chain. So that is what they were able to find. The true data could paint an even more worrying picture. MHRA sees 369 fake Ozempic pens, but they also have limited regular capacity. The real problem is when we start to move into online spaces. Like I said, it's very difficult for people to be able to identify what is a legitimate online pharmacy and what is illegal. So I'm Canadian, for instance. I could create a website, put on a white coat, Canadian flag, especially appeal to my American colleagues and say, cheap drugs, and we're nice, so you can trust us. And people will then be deceived. Some companies have gone so far, or should I say organized criminal groups, to even post fake reviews and customer service helplines. If I were to ask you here today, can you tell the difference between a legal online pharmacy and an illegal one? Could you do so with confidence? Well, let's play a game. If we go to the next slide, it's about coffee time break, so I thought, get you all involved. Which one do you think is fake? So, hands up if you think A is fake Ozempic or B. So, hands up for A. Hands up for B. It's about a split audience. What would you say, Susan?
I would say we don't have the right answer.
Okay, for those of you that said A, well done. This is indeed the falsified product, but they can be almost identical. So you could have both looking the same. You could only tell the difference through the barcode itself if you were to check that. So that becomes very difficult for consumers and patients alike to be able to discern the difference. And I think with this product in particular, there is the added sort of celebrity hype. We've all heard the joke that the Oscars were sponsored by Ozempic. The public perception of this drug is more as a lifestyle medication than a highly regulated product that has risks and requires clinical criteria. But it's not just these medicines that are at risk. WHO has received reports for all classes of medications, including cancer drugs, antibiotics, even cheap over-the-counter medicines. But could you imagine being a cancer patient receiving a falsified cancer drug, or your loved one, and what the cost of that would be, the consequences? Right now, we know that this is a high-profit, low-risk scenario, because if you were to sell a falsified cancer drug, you would receive less jail time than selling heroin. And so there is a big need for legislative and regulatory reform. Online pharmacies, about 42%, according to a recent study from 2024, shows that we have a high amount, almost half, that are either operating without a license or don't require a prescription, and therefore they're breaching regulations in some way. This is not safe clinical care, and it makes it even more difficult to identify which is a legal versus illegal online pharmacy when we have bad actors in that group. Approximately 20 new pharmacies that are illegal pop up every day, overwhelming regulatory capacity and creating a whack-a-mole problem where as soon as you shut down one, another fake pharmacy appears in its midst. Again, at the end of this, threatening patient safety above all. In the UK, the GPHC, which is our pharmacy regulatory body, is trying to tighten up the regulations around that, requiring further clinical screening. There's been a big boom in online pharmacies as well. From 2016 to 2021, we saw 301% growth. This trend has stabilized since. Pandemic were the good years, but we do see, in turn, brick-and-mortar pharmacies are starting to decline. 1,223 pharmacies closed in England alone, 7,000 in the United States. Some are now opting for a hybrid model, but the point being that if we are going to see continued growth in this space, we need to have the safe protocol alongside it. So that's taking me to my final message. We are here to talk about the Fight the Fakes Alliance, which is a group of stakeholders from all sorts of organizations, including GS1, that are trying to raise the awareness around this issue and implement feasible solutions. So I hope that you will join us in our mission, and thank you very much. It's a pleasure to speak to you today.
Thank you. Thank you. Well, thank you for that. I've been in this space and running hospitals for about 20 years, and I think that the reality behind why the standards are so important are becoming more and more important. And this issue of the cost of healthcare and pharmaceuticals is only going to drive this unfortunate problem even higher. So thank you for sharing that with us. What a great way to start our panelists. With that, I'm going to send it over to our virtual speaker, Nazneen Rahman, CEO of YewMaker, Director of Sustainable Medicines and Partnership. So over to you.
Thank you very much, Susan, and I'm really sorry I can't be there in person. It looks a wonderful venue, but I'm really grateful to have the opportunity to talk about medicine sustainability, which has been a passion of mine for quite a while. So I'm a doctor and a scientist, but I'm primarily a change maker. And about 5 years ago, I set up a purpose-driven organisation called YewMaker, and that purpose was to try and drive change to make healthcare more sustainable. Could I have the next slide, please? So a focus of our change has been this problem. So about 4.5 trillion medicines are made every year, but billions of those are never used. They never get to a patient, and they end up being thrown away for all sorts of reasons. And this has a huge cost, triple problems here. A huge financial cost, billions wasted every year, huge societal cost, 2 billion people can't access basic medicines that we end up throwing away, and a huge environmental cost. About a quarter of the healthcare carbon emissions are in medicines. Next slide, please. So to try and drive change in such a systemic problem, you need to have an army of change makers. So about 4 years ago, I set up the Sustainable Medicines Partnership, which is an action collaborative of 48 organisations, and GS1 has been a founding and really valued and important member of the SNP. And over the last 4 years, what we've been doing is building, testing, and hopefully then scaling sustainable medicines frameworks and solutions to try and reduce this, the avoidable waste of medicines. Next slide, please. So the first thing we had to do was have a conceptual framework, which we call the Pillars of Sustainable Medicines. And this outlines 6 things that need to happen in order for medicines to be more sustainable and for us to reduce that waste. Now, they're not the only things that you need, but they are certainly things that are needed and that we felt that we could build solutions and start to drive action. So starting the top left, the first one was to have measurable impact, to design and implement metrics so you can see where the waste is happening and how you can tackle it. The second is end-to-end visibility, having dynamic tracking through the supply chain. The third is to have a better shelf life. The shelf life of our medicines is not actually the time after which those medicines are no longer effective. It actually is the time up to which it was known to be effective at approval. That's typically 2 to 3 years, but there's abundant research to show that most medicines are effective for at least 5 years, and many are effective for decades. So we're unnecessarily throwing away medicines that could be used. The fourth is digital by default, ensuring we have accessible patient-centered information. The fifth is to make every dose use, and in particular to try and reallocate the unused medicines instead of throwing them away. And then finally, having more sustainable packaging, circular solutions to reduce the waste coming from our medicines. So you can learn more about those on the YewMaker website. But today I wanted to just lean into one of these pillars and to give you an example of a solution that we've been developing and hoping to scale out that's really been centered on the GS1 solutions. Next slide, please. So this is one of our digital by default solutions, and it's one that resonates with everybody because I suspect that pretty much everyone in the audience has had an experience of trying to read one of these patient information leaflets that are in our packets. The font is really small, they're really flimsy, you can't find what you're looking for. And in 2025, it's I think pretty surprising that this still remains the primary way in which we're trying to communicate to patients the information they need about their medicines. And it's simply not fit for purpose. It doesn't serve patient needs. It doesn't give them the information they need in the way they need it. It's squandering huge amounts of planetary resources. Conservatively, about 100 billion of these types of leaflets are made every year. Most are never read and they end up being thrown away. And in myriad ways, it leads to medicine delays and wastage. But there are solutions that we can implement. Next slide, please. What we need is to have accessible, integrated information. And we don't need radical new innovations or technology here. We have the components, we have to put them together and we implement them. So legitimate medicine packets all have to have a barcode that is mandatory, that has the product information on it. We know we have the patient information that's available. We know that virtually all of us now have in our pockets tools by which we can access that information and read it if it was linked and we could access it. And one of the things that could do, following on from Oksana's inspirational talk, is it could be a way in which we could check, the patient could check whether or not that was a genuine medicine or a falsified medicine. So what we were doing in the SMP is we first did a really simple pilot. Next slide, please. And this was really led with by GS1 and Google, two of our SMP members, and ourselves at YewMaker. So here, this pilot was really simple. First of all, can you use your phone to read the barcode? YewMaker is a fictitious medicine that we use for this purpose. We don't make medicines. But can you then link that out to just a PDF of that patient information leaflet? So that was our first simple pilot, and that works. Next slide, please. The next step is, okay, how can you scale that solution? So there are, I suppose, three phases to that. There's the technical aspect of that solution. Then there's the implementation, what kind of regulatory, and then there's just leveraging and harnessing all of the impact you can have. So the technical solution, as I say, this is really being worked out and led by Google and GS1, is we already have on our medicine packets the barcodes. Google Lens lends itself to being the technical interface on our phones, and that's because Google Lens works with both Android and with iPhones, so it's agnostic there, so it could be used for all of those. You can use the GS1 digital link to go to a resolver that then goes to the company website so you can ensure you're going to your approved information. So that's the technical piece that is absolutely good to go. Then that opens up a world of possibilities. So yes, you can go to the PDF version of the patient information leaflet, but now you've got a digital link, you can potentially access that in all sorts of ways. Any language you want, that would make a huge difference. You could have it as audio if you're visually impaired. You could have a video, particularly important for things like inhalers or medical devices that are really hard to read in information. And it would always be up to date, which is, again, another problem. It would be searchable, and it potentially could be linkable. And you could link out to all sorts of things, including potentially the EPR, and we're going to hear about that in our next talk. So I wanted to show this because it really highlights the potential power of everything that GS1 has been building, but also I like it because it's really quite a simple and elegant solution that we could deliver today and could lead to huge positive impacts for patients and reduce of waste in all its different formats. So you can learn more about the work that we've been doing at the SNP at the YewMaker website. Thank you for your attention, and I'll hand back to Susan.
That's terrific. Wow, what a fantastic presentation. Thank you for that. Two things came to mind when I was listening to you. The first is that in healthcare, we're always trying to get patient information and patient education at a grade 6 level in the language of choice for the patient. And yet the medicines that we give them to address their healthcare issues are not there. And so thank you for addressing actually one of the huge inequities that we have in healthcare. This is hugely impactful. And then I think the second thing is that you've really taken two major pillars, sustainability and healthcare, and you've put them together. And so thank you. This is going to be really, I think, fantastic as we go forward. And thank you to working with GS1 to ensure that it is standardized as such. We're now going to have our third presenter come up, and I want to introduce and welcome Tracy McClelland, who is the Chief Clinical Information Officer of Dedalus UK. Tracy, please join me.
Thank you very much, Susan, and thank you to GS1 for inviting me. So, as Susan said, I'm the CCIO for Dedalus UK NI. I am a nurse by background, and I specialised in oncology and haematology before moving into the digital healthcare space around 10 years ago. I moved into digital to support whole genome sequencing in a time when it took about 2 weeks to sequence a genome, and consultants didn't have the availability to be able to prescribe against the medications that were reported back from the sequence. Nowadays, it takes less than a day to do a whole genome sequence, and there are untold numbers of precision medicines and targeted therapies available for doctors to prescribe to. I moved into digital and worked with Dedalus about 6 years ago. As for me, I really do feel that if we can get software right for healthcare clinicians throughout the hospital, we can really help drive efficiencies and improve patient care. And Dedalus was the right move for me, and it is a company created by a clinician with all of our software solutions built by clinicians and for clinicians. I would say Dedalus is somewhat unique, as innovation and patient centricity are at the heart of our designs, and open standards are incorporated into all of our solutions. We work very closely with a number of other organizations, including GS1, and have a number of our clinicians who participate and even co-chair the GS1 demographic mission working groups. Not only does Dedalus incorporate open standards such as the GS1, GSRN, FHIR, HL7 and Diacom into our EPRs and clinical solutions, we provide data platforms to share data between different software solutions. We provide the terminology server to NHS England, Canada, the Netherlands and the HSE for medications. And we provide other apps, such as an app which allows the patients to have the full record in the palm of their hands, should the healthcare provider choose to release it. We also enable clinicians who work in the community to have access to the full medical record and work offline. And any work they do whilst they're working offline automatically uploads back to the EPR when the connectivity is re-established. None of that would be possible if you couldn't barcode scan and be absolutely convinced and trust that the information that you have in front of you is about the correct patient. So I'm now going to give you a brief history of the EPR. So when I say EPR, I mean the electronic patient record. This is used interchangeably with EHR or EMR, depending upon which country you're from. But in the UK, we use EPR. So if you go back to when I first qualified in the late 1990s, I do like to use ChatGPT to create my images. This is somewhat correct. And so you would have reams and reams of manila folders full of paper back in the 90s. You wouldn't have the doctors and the nurses working out of a room such as this, but you would have lots of notes in the doctors' clinic rooms while they were waiting for their patients to attend. You wouldn't have paper all over the floor. But the biggest mistake in this image would be the flat screen TVs. You didn't have flat screen TVs in the 90s. Now, some of the biggest risks associated with the dawn of the EPR, so when you were heavily on paper, might have had some digital systems, would be that you would firstly be unable to locate the patient's file. As a junior nurse back in the late 90s, I would spend hours trying to find the patient's record. The patient would attend the ward, and the record wouldn't be there. I would have to go round to the outpatient departments, the ED, anywhere the patient might have been in the last 6 months to try and locate this folder. And then if I did locate the folder and brought it back to the ward, there was a risk that actually the doctor hadn't yet updated that record, because that would be why it wasn't back in the medical records department. There was lots of risks with misidentifying patients, with blood transfusion errors and medication errors. One of the worst instances I can think of was a junior doctor completing a mini-mental assessment on a patient who was having neurotoxic treatment for chemotherapy. He picked up the folder, went into the patient, did a full assessment, came back absolutely panicked. This patient has no idea what their name is, when their date of birth is. We need to stop treatment. We need to put a big sign up. And the nurses who knew the patient were very surprised, because we hadn't noted that the patient was confused. Now, what had happened was that the room was numbered 7 and 8, not 7 and 8. And the doctor had picked up the wrong medication, the wrong patient record, and gone into the patient's room, sat with them, and then when the patient had given their correct name, the doctor was actually wrong in terms of the fact that they had the wrong information in front of them. So this is the level of risk that you can have if you have the wrong data in front of you. So if we move to today, we now have integrated digital solutions, meaning that we're able to share the digital record between those handheld devices, the medication devices, and the central EPR. Now, the EPR is the central record for all of the digital data for the patient in the acute setting. We're able to share information from primary care back to secondary care. So that's not fully adopted yet, but you are able to do that. And that's because we have those open standards available, using that data between the systems. And as I said, it's not universally adopted. The GS1 GSRN unique patient identifier ensures accuracy in the patient information. So if you as a doctor are going to a patient, we now have the confidence that when we scan the patient barcode, obviously we communicate with the patient to confirm the name. We can be absolutely confident that the information that we get up on that patient is absolutely the correct patient and not somebody else, which is extremely important these days. We have instances when our consultants and our doctors are using the GS1 barcode in emergencies at patients unconscious. You scan the barcode, and immediately, whilst you have people working on the patient, you can have all of the medical history right there in front of you in the palm of your hand. We have handheld devices which enable you to have full EPR access. And we have the dawn of AI. So at Dedalus, we are starting to incorporate AI into our solutions. We support clinical decision support with AI, and we have some ambient listening in terms of the functionality. We're being very, very cautious because we believe, there's this huge juggernaut of AI coming at us, which is absolutely brilliant in terms of opportunities, but we do need to make sure that we adopt it with caution. So let me take a trip to the future. What would we want in terms of the future of the EPR? So our goal would be to have healthcare becoming more preventative and less reactive. That we have less attendances for patients in acute healthcare facilities, that we're able to treat patients at home, or even have them managing their own healthcare. So patients will have access to their information on the handheld devices. All of the wearable devices that patients wear will share back automatically to the EPR. So how would we get to this utopia, which, by the way, is a strategic goal for most of the countries in Europe? So the UK at the moment is driving to shift care to the community. I know that Germany is doing the same, as is Spain and France. So we would need open standards. We'd need a global adoption of the GS1 standards, not just for patient identification, but also, as our previous speakers have said, around medication management, blood transfusion management. You can track the source of the blood right through to the administration, so that safety of that tracking of the blood from start to finish. We have open EHRs so we can share that information from system to system, and having cloud-based data so that you can share that huge amount of data. If we now incorporate and think about the fact that we want to use whole genome sequencing data there as well, we're able to share that data in a secure way up into the cloud and back down to the EPR. We will have AI, and as I said, with some modelling guidance as per the EU AI Act, and adherence to GDPR. So we want to make sure that whilst we're enabling that data to be available, that we're doing so in a really, really safe way, so the patient has confidence that any information about them is shared and secure. And we have large-scale quantum computing functionality to enable the information to be worked in a much, much faster way. So how does that look in terms of the future for global digital healthcare outside of the EPR? We would have better global digital healthcare by enabling global connectivity. Again, having those AI-powered EPRs. The amount of data we'd have on the patient if we incorporate and include the whole genome sequence means that we can move much more to preventative care. We can have digital twins for the patient, which means we have all of the information about the patient, including their whole genome sequence, enabling doctors and nurses to be able to trial medications on patients without actually administering medications on patients, and be able to assess what the potential outcomes would be. So that's a way of moving to the future. Also, very much across the world, we're looking at population health data. So what trends have we got in terms of A&E attendances? Are pandemics due? What resources do we need to put into different parts of the hospital to manage the trends that are coming for winter or when there's different diseases around the population? So in conclusion, because I think I've run over, the next 25 years of EPR-driven healthcare will require cutting-edge software, next-generation hardware, global regulations, and an AI-driven interoperability. Achieving this vision will demand international cooperation to create a secure and patient-centric healthcare ecosystem. And I think central to all of this, regardless of what data we have, if we don't have the correct patient identifier for each individual patient, the rest of the data is irrelevant. Everything we put into the record has to be accurate, starting with that individual patient. And I thank you very much for your time.
Please join us. Well, thank you for that. Again, an outstanding talk, and really it goes back to the fundamentals of trusted data. I think, it's true, the electronic medical record or the EPR, whatever we call it, regardless of the country, was one of the major disruptors in healthcare almost 2 decades ago. And yet, I think today we would say we could not take care of a patient without it. So thank you for leaning into it to make it as smart and as trusted as it can be. So thank you for that. Well, the time has come now to think about the homework question that I gave you at the beginning of this session. And I think now, having listened to our 3 panelists, I think we probably all have an idea of what success looks like and what we can all hope for. So again, the question I'm going to ask you, but I am first going to ask my panelists. So we're going to give you a little time. And the question is, what is your one wish for healthcare in the next 20 years? I think it's fair to say that my 3 panelists are forward-facing, are futuristic. What would it look like? What is your wish? And how would you describe it in a word or 2? So maybe I'll turn it over to Nazneen first, who online, and then I'll ask Oksana and then Tracy. Nazneen?
Yes, thank you, Susan. My one word would be accessible, and I would mean that in the broadest sense. I want not just the medicines or the actual healthcare to be accessible, but the information, the support. I would like people to feel that they have agency over their own health, and be able to make those informed decisions that would allow all of us to be as healthy as possible. And I think that starts with accessibility, and I think the digital tools and revolution that's upon us absolutely gives us the opportunity to deliver on that.
Great. Thank you for that. Oksana?
Building off of that, I would say access to affordable, safe, high-quality medicines. And I think in order to achieve that, we need to hold social media companies accountable, which we currently do not at all. There's no regulation to be able to take down. So I'll give you a very short anecdote for this, where parents have reported medication that has been purchased, prescription medication, that ended up killing their teen, and that social media platform remains active with the seller continuing to have that product up. So in order to have that, we need to be able to put the appropriate punishment in place, and regulation is the key to that.
Great. Thank you for that. And Tracy?
My one word would be fair, but I'd add to that and say efficient, fair, and human-centred. So ensuring that we have the patient driving their healthcare, that everyone has access to their healthcare records where possible, and that we're as efficient as possible, both for the patient in terms of their journey through any healthcare condition, and also for the clinicians, so they have all the information they need at the point of care for their patients.
That's excellent. And I think after listening to my colleagues today, I think mine would be trusted. And I think through the standards, we can truly make all of the data, the use, the accessibility, the access, trusted. So with that, I'm going to thank my panelists. Thank you so much. And online, thank you so much as well. And then I'm going to turn it over to Geraldine, the Vice President of Healthcare. So thank you. A round of applause for my colleagues. Thank you.